Hello and welcome to your Hematology Medications lecture. Medications that are affecting coagulation is going to be the first subcategory here. Okay, so our first classification is going to be anticoagulants. The therapeutic use or expected action for anticoagulants is going to either be to prevent a clot being formed or to break apart an already existing clot. Our medications exemplified, so examples of this classification are going to be heparin and enoxaparin. The complications are going to be the bullet point items. So for heparin, we usually use this for stroke, pulmonary embolism, DVT, or prophylaxis against a clot being formed prior to a major surgery. Complications associated with this is going to be toxicity, and so heparin-induced toxicity is going to be when the blood is too thin. So we're using this as an anticoagulant to thin out the blood, but if there's too much heparin, then the blood is too thin. So we're going to monitor these levels by the PTT level. So if the PTT level is too high, then we're going to consider it as toxicity, and we're going to administer protamine sulfate as our antidote in this case. So it's going to bind to those heparin so that it's not causing the effect. Our general rule of thumb is to keep the heparin level 1.5 to 2 times their baseline level. So we'll take a baseline before therapy, a PTT level, PTT and INR, and during therapy, to make sure that we have a therapeutic level, we're going to be monitoring that PTT level again. And so if your baseline level, say, is 2, then 2 times 2, I want it therapeutic to be 4. So whatever the baseline level is, 1.5 to 2 times is going to be the therapeutic expectation, as long as the baseline is considered normal. So then here's your second one. So hemorrhage is also associated with anticoagulants related to a high PTT level as well. And if this happens, such as signs of bleeding, signs of hemorrhage, a firm abdomen, a firm leg, any area that it could be bleeding internally or externally, then of course we're going to need to stop heparin. And then there is heparin-induced thrombocytopenia. So this is HIT. So you'll hear this commonly in practice, especially if you go into any critical care area. Heparin-induced thrombocytopenia, HIT. This is going to be due to the due to the heparin that we're giving, also affects the platelet count, and then if the platelet count drops too low, this is considered a thrombocytopenia, but it's caused by the heparin. And so our rule of thumb here is going to be 100,000 platelets. So if it drops below 100,000, then we're going to consider heparin-induced thrombocytopenia. We need to stop the heparin and consider them to now have a heparin allergy. And then we're going to wait for their platelet count and notify the doctor, wait for the platelet count to increase, and then if they are going to need to stay on a blood thinner, they're going to need to use an alternative form and not a heparin-based form. So the other example here is the enoxaparin, and so this is a low molecular weight heparin, so that's what LMW is. We use this also postoperative for DVT, PE, or prevent complications of angina or myocardial infarction. As this is a type of heparin, it has the same complications as heparin. Now, because it is a low molecular weight, it has a less frequency of these complications. So then you'll notice here the arrows are going to be your nursing interventions for these complications. The next classification is going to be your vitamin K inhibitors. These are going to be your coumarins. So these are going to antagonize vitamin K, which is a clotting factor. So then therefore it is preventing clotting factors from developing and therefore preventing clotting. And so if you prevent clotting, then you're not going to clot. So warfarin, also called Coumadin, is the brand name, but your generic here is the warfarin. Our complications are going to include hemorrhage again. So monitor your coagulations, your vital signs for an increased heart rate or decreased blood pressure. It's going to be your signs of initial hemorrhage. And then assessment items such as bruising, petechiae, hematoma, and black tarry stools. And then we're going to need to administer vitamin K as our antidote. So this is antagonizing vitamin K. We're going to overwhelm it with vitamin K so to make sure that the vitamin K is being brought into the cells and therefore clotting. That's if we're seeing these signs of hemorrhage and they are on warfarin. Then our next one is hepatitis, because vitamin K is developed in your liver. If we're antagonizing a part of the liver's normal processes, a condition that can happen is hepatitis. So we're going to need to monitor their liver enzymes and assess for any signs of jaundice as well during therapy. And then the last specific one for this area is going to be toxicity. So this is going to be similar to hemorrhage, but more so. And then we're going to see like your PT, PTT, INR levels are going to be drastically increased. So we're going to need to administer vitamin K, but do it very slowly. And then administer FFP, which is fresh frozen plasma. So fresh frozen plasma has all those clotting factors in there and will help the body begin to clot again if the bleeding is not controlled by administering the vitamin K. Direct thrombin inhibitors are going to be used to bind and inhibit the thrombin, which is another clotting factor. So all of these essentially are going to have similar effects, but what clotting factor or what part of the clotting cascade is when it's intervening is where it's going to have its effect. So examples are going to be your argatroban and dabigatran. Argatroban is the big one. So this is what we use in place of heparin, especially after a heparin-induced thrombocytopenic episode. But make sure that heparin has been discontinued and we know that what their PTT and INR levels are prior to starting argatroban. Remember, we always need a baseline, but usually in these cases, we're already on heparin, switching to argatroban in this case. So their PTT INR levels are likely to be quite high. They may be therapeutic because remember, this is based off of their platelet level per hit. So just make sure that you still have a new baseline. You draw a new set of coags before you start the argatroban. So our complications are going to be here for bleeding and GI effects. So for bleeding, our antidote for argatroban is going to be idorizumab. Yeah, I don't know. So I remember this is I don't know drug because it's idorizumab. I don't really know how to say it, but I call it the I don't know drug. So the argatroban is the I don't know drug antidote. Other interventions are going to include dialysis or injections of recombinant factor 7A. This is going to be your other options for if they can't have the I don't know drug, or if they don't recover quickly and they're still bleeding, if it's not being effective. So then we may need to dialyze them to try and filter out this medication from their bloodstream. Or the recombinant factor 7A is the clotting factor that will promote clotting again. So then our second complication are going to be the GI effects for nausea, vomiting, reflux, and ulcer formation. So make sure that we're taking this with food. We can take it with omeprazole or H2 receptor antagonist. But remember now, ranitidine is no longer on the market due to, and so we should not be including this in the client's education any longer. So this is the newest research as of 2020. So make sure that you are aware of that. So don't suggest ranitidine to them. Direct inhibitor of factor 10A. These are going to inhibit factor 10A to prevent formation of thrombin, thereby preventing clotting. So rivaroxaban is going to be used as our example here in this category to prevent stroke in clients that have atrial fibrillation, which is a cardiac arrhythmia where the heart does not fully pump completely. The atrium specifically does not pump efficiently, and therefore blood is pooling into the atrium and pooling, just like stagnant water, stagnant blood causes clots. And so anyone with atrial fibrillation should be on a blood thinner, and this is usually one of those medications that are used, rivaroxaban. So our complications here again are going to be bleeding and liver enzymes due to where it's acting on. So remember your bleeding signs, and then you're monitoring your baseline levels and liver functions, but your antidote here is going to be administering factor 10A. So if most of these going forward, and the last couple ones, you'll notice that if you know how it works, then you know the antidote, right? Or vice versa. So giving factor 10A to decrease the bleeding if toxicity is suspected, and dialysis and charcoal also can be considered. All right, antiplatelets prevent platelets from clumping together and thereby preventing clotting. Examples are going to be aspirin, the ABC drug, and clopidogrel. The GI effects are going to include nausea, vomiting, dyspepsia. So education to take with food, proton inhibitor, monitor hydration. Hemorrhagic stroke. So signs and symptoms here are going to be key to know. Monitor for weakness, dizziness, and headache. So hemorrhagic stroke is a bleed in the brain. And so that built up blood and pressure on the vessels and pressure on the brain, because that bleeding is creating a cavity full of blood. So it's going to interfere with thoughts, cognition, motor, wherever that bleed is occurring. That part of the brain is not being perfused as much. Other complication in bleeding and thrombocytopenia. So signs of bleeding, coffee ground emesis especially, and then bloody tarry stools, petechiae, bruising, and gum bleeding. So make sure that we're looking at their coagulation levels. Tinnitus, which is the hearing loss and the ringing in the ears. So if they have this, tell them to hold their medication and tell their doctor. And then hypotension and bradycardia, why did I say O? So hypo, so low blood pressure and a low heart rate are common with antiplatelets, so we need to monitor for that. If, especially if this bradycardia becomes tachycardia, I don't know why, I'm just getting all my words mixed up. So hypotension and bradycardia, we need to monitor for their platelet levels and monitor them very closely. But if their bradycardia becomes tachycardia, then there's your symptoms for bleeding, your assessment findings. A low blood pressure and a high heart rate, then you have blood loss. So make sure that you know the difference of symptoms there. Thrombolytics, these are your clot busters. So these dissolve clots that have already formed by destroying fibrinogen and other clotting factors. So your examples here are going to be alteplase, retiplase, and TPA. This is going to be your big ones. So these are what are given for stroke that are caused by clots. Major clots that are obstructing perfusion to peripheral areas. So you're going to monitor very closely for bleeding, either internally, superficially, or externally. So make sure that we limit venipunctures and injections. So before you start a thrombolytic, you need to make sure you have all your IVs. You go ahead and put in a Foley. You put in anything that you need before you start. Because after you have started this medication, any little thing that you do to them, they're going to bleed. So if they need frequent blood draws, which they probably will because they're on this clot buster medication, might be a good idea to go ahead and get a central line so that the nurse can pull labs instead of constantly sticking them with butterflies or whatever every morning to get levels, in addition to the other ones that may be drawn during the day due to being on alteplase. So if there is a venipuncture that happens, we have to hold pressure for 30 minutes, and that is a very long time. So limiting anything that breaks the skin because they will bleed. Applying pressure to dressing to recent wounds. So if they have a bandage already, you need to go get an ACE wrap and apply pressure to and reinforce that dressing because it will start bleeding. Monitor their vital signs, level of consciousness, signs of weakness, and other signs and symptoms of intracranial bleeding. So the hemorrhagic stroke, remember? So monitoring their coags, their hemoglobin, the hematocrit levels. Make sure that we have an accurate weight, as this medication is administered via weight-based. So we need to know exactly how many kilograms they weigh so that we can measure their appropriate dose. They may be required to have a blood product replacement. So make sure that we have a type and screen on file before we start. And if we have any signs, symptoms of bleeding, then we can administer imidacloprolic acid to reverse the effects. We also need to make sure, I scrolled on too fast, that we have beta blockers on their medication profile so that it can help with any antiarrhythmias due to such a thin blood flow that is circulating and their body's not used to it. So make sure that that is on board. Coagulation interaction. So this is going to be for this entire classification of blood thinners, the anticoagulants. So in general, any of these medications that you mix with feverfew, garlic, ginger, glucosamine, ginkgo biloba, and saw palmetto are going to increase the effects of any blood thinner because they are already herbal supplements to promote perfusion. And so if you promote perfusion and thin out blood, and then you're also taking a blood thinner, you have bleeding. And so you have here your 4 Gs. There is a 5th G later that we'll go into with ginseng, but ginseng does not affect coagulation in this effect. But so especially for NCLEX, on your NCLEX review, they'll go over, remember, your 5 Gs, 5 Gs, 5 Gs, but only 4 are in effect with anticoagulants. So you need to also know not just prescription medications when you do an intake on a new client, but you also need to know anything that they're taking over the counter, including herbal supplements, for this reason. If they're taking any antivirals or antifungals, caffeine, NSAIDs, and any other anticoagulants are also going to have your double whammy effect and increase your chance of bleeding. Dark green leafy vegetables, oral contraceptives, anything with vitamin K, recombinant factor 7A or factor 10A, of course, specific to their medications. And then phenytoin and phenobarbital are going to decrease the effects. So we're taking it for a reason. And so if we're going to take something else to decrease the effects, then why are we taking this medication? So make sure that especially females are aware with taking oral contraceptives. Oral contraceptives have its own effect of promoting high incidence I shouldn't say promote, but a high incidence of blood clots developing during oral contraceptive therapy. And so taking something that promotes clots, whereas you're trying to take something to prevent clots, doesn't make sense. So females that are taking oral contraceptives, and then dark green leafy vegetables is the big thing there, especially with coumarins. So Coumadin, warfarin is going to be education for at home so that they avoid dark green leafy vegetables. Our next section is going to be growth factors. So erythropoietic growth factors acts on the bone marrow to increase production of red blood cells. So these growth factors are going to act on a different way. So look at the effect. So I am taking erythropoietin to increase my red blood cells in this case, right? So this is going to be to treat anemia related to chronic kidney disease, chemotherapy, or antivirals, such as for HIV. So if I'm taking this to increase my red blood cells, then I need to monitor my levels. So my goal, because it's for anemia, is going to be to monitor my levels of hemoglobin and hematocrit. So my hemoglobin needs to be about 10 or 11. That's still on the low side, but they were anemic before. So this is actually a drastic improvement. So 10 to 11 hemoglobin or 33% hematocrit is our goal for therapy when starting erythropoietin. But our conditions that we're going to need to monitor for during therapy are going to be for hypertension. So as the nurse, you're going to monitor their hemoglobin as well as their blood pressure and administer any antihypertensives if needed. A thrombolytic event, so a clot formation, so myocardial infarction or stroke, seizure, anything that's related to elevated levels in a short period of time. So if this happens, then we need to stop the medication and resume hemoglobin levels when hemoglobin levels drop to acceptable levels. Again, refer to your goal. So if it's above 10 to 11, if it's like 17, then we are at risk for a thrombotic event and we need to stop the medication for a short period of time until our hemoglobin has reached normal levels. And then consider a dosage reduction when we do restart the medication. Also, there is the concern of DVT. So this is going to be also more so if a client taking erythropoietin is going for surgery, then they are likely to have a DVT after surgery. So we recommend giving them a prophylactic anticoagulant to prevent DVT after surgery. Headache and body aches. If a client has frequent or severe headaches, this should be reported to the doctor. It may be related to hypertension. It may be related to a stroke. So a headache is not something that you need to ignore when messing with their clotting vectors or increasing their hemoglobin and hematocrit at this point. Their blood is getting thicker because you're increasing the red blood cells. So we need to be mindful of that. Leukopoietic growth factors are going to stimulate the bone marrow to increase production of neutrophils to decrease the risk for infection for those that have neutropenia. Example here is going to be our filgrastim. Our goal is going to be related to our white blood cell differential. So we want all of our white blood cell differentials to be in normal ranges, and of course the absence of infection. We need to monitor for bone pain. So if they have bone pain, we can administer acetaminophen or an opioid if not effective, because they're already at like a very weakened state. So they're going to be more likely to feel bone pain, just generalized bone pain, due to this leukopoietic. So leuko, white blood cell neutrophils. Leukocytosis, so monitor their white blood cells twice a week. And so we're going to need to stop it if they have white blood cells that are above 100 or absolute neutrophil count that's above 10. So leukocytosis is an overdose of leukocytes. So if you think of it that way, so an drastically increased white blood cell or drastically increased neutrophil count is going to be very concerning. Of course, we also need to make sure that this is not due to a super infection or sepsis, but once that has been ruled out and we realize that it's the medication, then we need to stop the medication. Our other concern here is splenomegaly and risk for splenic rupture. So a left upper quadrant abdominal pain may be reported by the client and shoulder tip pain. So it will radiate to their shoulder. Should be reported to the provider. Sometimes it can be confused with chest pain. So this is acting on the neutrophils and clotting factors, which we're thickening the blood because we are increasing white blood cells, right? It's not clotting factors per se, but it's thickening the consistency of the blood, the osmolality of it. So a thicker blood and your spleen is your filter, essentially, then it's likely that things can get stuck in there, so you will have more stasis and then lead to blood clots in your spleen. And then also if it gets too full, it can get too large and then rupture that way as well if it doesn't clot first. Granulocyte macrophage colony stimulating factor. So this acts on the bone marrow to increase production of white blood cells. All of them, not just neutrophils. That's the difference here. All white blood cells. This example is going to be sargramostim, used to hasten the bone marrow function after transplant. So transplant of like an organ, if they've got a new kidney or a new heart or a new liver, and they're on methotrexate or something that is affecting their immune system to prevent rejection of the organ, we may want to stimulate their white blood cells so that we can prevent infection as well as preventing rejection of the organ. So our goal here is going to be that our white blood cell differential are in normal ranges and again absence of infection. Again, here you have your leukocytosis and thrombocytosis, but here remember, since it's all white blood cells, we also need to be mindful of what's going on with our platelets because of how thick the blood is getting. The platelets may not be produced as much, and so or it affects the platelets, but it's not too much. Oh yeah. And then we have other symptoms of diarrhea, weakness, rash, malaise, and bone pain. So again, there is your acetaminophen. Okay, so the last growth factor are going to be the thrombopoietic growth factors. These are going to act in the bone marrow to increase production of platelets. So these are directly related to platelets. So then we're treating a platelet disorder called thrombocytopenia. And the example here for thrombopoietic is going to be aprivlicin. Our goal then for therapy is going to be based on our platelet level. And so we want to increase our platelet level to greater than 50,000. Some concerns to watch for during this time are going to be fluid retention, cardiac dysrhythmias, eye effects, and an allergic reaction or anaphylaxis. So again, here you have with the arrows your nursing interventions that you can perform or educate about for a client that may be having these, and make sure that you again know how to assess for fluid retention, assess for cardiac dysrhythmias and eye effects and allergic reaction. What do these things look like? So contraindications and concerns for growth factors. This is going to be for all of the growth factors. If a client has a history of hypertension, bone marrow cancer, sickle cell disease, respiratory disease, breastfeeding, or they are a child, then we might need to not consider this as an option for a treatment. It may be a last resort, but definitely not a first line of therapy for these types of clients. And also for preparation, do not shake or agitate the vials. These are small vials that you will have to extract the medication from, and if you ever have to do these are ones that you do not shake or agitate. All right, the last section here we're going to be covering blood and blood products. The types of blood products are going to be whole blood, which is going to be the entire circulating blood volume, and then you have packed red blood cells. This is going to be used for anemia, and so we're going to need to monitor hemoglobin and hematocrit. And then platelet concentrate, then we're monitoring for platelet count. Fresh frozen plasma, FFP, we're going to be monitoring for coagulation factors. And apheresis granulocytes are going to be to treat neutropenia. And then albumin is going to use to treat, expand the volume of oncotic pressure. So in conditions such as hypovolemia, burns, ARDS, and other problems that you don't have much blood volume and trying to make the most of what little volume you have, essentially. We use albumin to expand that volume. All right, so first, before we can administer blood product, we need to know blood type and cross-match. So these are going to be blood draws that are going to be in the pink lab vial tube. And so we're going to need to know what blood type the client is so that we can give them a blood component that is compatible with their blood type. So you need to understand blood typing and cross-matching. So your blood has 3 different types of antigens, essentially. You have an A and a B antigen, and then you have an RH antigen. The A and B is, of course, where we get our ABO blood type. If you have an A antigen, then you're type A. If you're B antigen, you're type B. If you have an A and a B antigen, then you're type AB. But if you have neither A or B antigen, then you are type O. Now, the plus or minus, the positive negative, is going to be determined by the RH antigen. So if you do have an RH antigen, then you are type positive. If you do not have the RH antigen, then you are type negative. So like O positive only has an RH antigen. They do not have an A or a B antigen. So make sure you understand this. Because that means for transfusion, you can only get what you've already have. So you cannot receive a blood component that has one of those antigens that you do not have. Otherwise, you're going to have a reaction, right? So if a person is AB positive, then they can receive A negative, B negative, A positive, B positive, O negative, and O positive, right? Because the A negative means that they don't have the RH, but that is being transfused to them. It doesn't matter if you don't get something that you already have, but you can't get something that you don't have. So then in the case of AB negative, they can only receive those that have the negative strand, but they already have A and B. So the ABO type antigens, it does not matter. So they can receive A negative, B negative, AB negative, and O negative. Now, in healthcare, often we try to match as close as possible. So someone who is AB negative will receive AB negative or O negative. And so it's not a big thing in practice, but as we are continuing to encounter more and more blood shortages, these are things that you may need to understand. Especially for things like platelets. There are less and less platelets on the market now. So sometimes, yes, you will be infusing to an A positive patient platelets that came from an A negative. And so you have to recognize and not waste time with the blood bank saying that, oh, you gave me something that is not compatible. Technically it is. If it's A negative giving to an A positive, that is compatible with that client. But you still need to monitor regardless of what type of component you're getting. For transfusion reactions. Now, with your transfusion reactions, there's multiple types. And so a lot of symptoms overlap. So I tried to make like this table so that you can see the symptoms and how to pair them up. So acute hemolytic reaction is going to be a transfusion reaction, and the client may exhibit chills, fever, increased heart rate, an increased respiratory rate, and signs and symptoms of shock. So acute hemolytic, hemolysis, meaning the cells are being broken down, they're being lysed apart, and so you're gonna have all of these symptoms, and especially the shock and your symptoms there with your vital signs, because the body is breaking down all of the cells. Whereas a febrile non-hemolytic are still going to have the chills and the fever because it's febrile, but then you don't have the hemolytic symptoms, but you do have the headache and the anxiety. But headache and anxiety can also be with severe headaches. Severe fever, right? But they don't have those hemolytic symptoms. Anaphylactic is going to include anxiety, wheezing, and signs of shock. Mild allergic is just going to be a little bit of anxiety. They might have like a superficial thing going on, but it's not the same and drastic as you can see as anaphylactic is. Circulatory overload is going to have increased heart rate and crackles on their lungs. So this is where the fluid is too overwhelming for their circulatory system, and that fluid is going to displace on the lung fields. So then you're going to hear that wet crackle popping noise on their lungs as the lungs try to inflate and deflate around liquid. And then sepsis, infusion reaction, is going to have chills and fever because it's an infection, and signs of shock. So this can happen usually can happen within a couple of hours, actually. You think of sepsis as being like this long process, but this is being infused directly into their circulatory system. So it does not take long for all of their organs to start shutting down if there is a contaminant in the blood product. So chills, fever, and signs of shock are going to be very likely and can be very deadly very quickly. Hyperkalemia reaction is going to have signs of shock and paresthesias, so the tingling sensation, and we're going to need to monitor for their heart rate and cardiac arrhythmias, of course, because of the potassium levels. This is also going to be something that with these paresthesia and things, they may start to freak out, so they may get some anxiety, but it's not always. This is more anxiety based off of their mental coping mechanisms, and that's why anxiety is not necessarily X'd here, but to be mindful of other things that may be going on with the patient so that you can assess for these things, like signs of sepsis besides a fever. You may have a change in vital signs, but again, the X is not marked here for your increased heart rate and increased respiratory rate because it may be decreased, it may be increased, it changes early versus late, and so still be mindful of those things. Just because it's not X'd here does not mean that it does not absolutely ever exist. It just means that this is not the always situation, or almost always. And then also before I get to this last one, this is the things that are the most identifying factors of these types of transfusion reactions, I guess I should say. So these sets of symptoms should make you point to this type of reaction. So with like transfusion associated graft versus host disease, graft versus host, just like with transplant, where the body is now rejecting the organ, the body is rejecting the blood. But this isn't going to occur immediately. This can happen weeks after the transfusion has happened, even months. And so they may not have any symptoms during the infusion or immediately after of any of these other signs, but they're going to come in with fatigue and weight loss, and just not feeling right, not feeling well. Their whole body is just achy. So the most indicative thing here is going to be that weight loss is going to be keying you into they've had a recent transfusion and they have lost weight in the last 2 months. And so maybe we should look at this being a possibility of what is going on with them. So nursing interventions for these types of reactions. So with the acute hemolytic, this is when we're going to need to stop the transfusion. A lot of these initial ones especially are going to be stopping because these happen pretty quickly during the procedure of transfusing it. We're going to infuse normal saline. That's what this NS is. So normal saline is 0.9% sodium chloride. So we're going to need to stop the infusion. You're going to disconnect it from the IV site and then flush new normal saline to it. You don't start normal saline to the same tubing because that 10 cc's of tubing of blood that they're having a reaction to, you're now going to give them extra 10 cc's that they don't need. So completely get rid of the tubing, or disconnect it, I should say, and reconnect a new tubing for normal saline. Flush the IV site so that the hemolytic, the inflammation reaction that is going on, hopefully we do not lose an IV access, and then make sure that you notify the provider. Of course, everything is going to be, if there's a bad problem going on, notifying the provider, but that is not going to be necessarily the first thing that you're going to do, because these are emergency situations. And so if the client is having a reaction, you as the nurse need to do something first, and then once the client is stable is when you notify the provider. Now, with febrile non-hemolytic reactions, same thing, stop the transfusion, hook up normal saline, notify the provider, and he's probably going to give you an order for acetaminophen, or if you already have an as-needed PRN, then go ahead and give them the acetaminophen, but still notify the provider that they've had this reaction. Anaphylactic reactions, of course, stop. Notify the provider, provide that normal saline, CPR as needed. So if they need airway management, if you need to save their airway by intubating them, you may have to. And then epinephrine, of course, is going to be your choice of drug to make sure you have all the standby and available for when the physicians come to intervene. Mild anaphylactic, stopping the transfusion, notifying the provider of normal saline, but then your treatment here are going to be antihistamines. So Benadryl, which is diphenhydramine, is going to be one of those types of antihistamines. We also have other antihistamines that we'll look at later. Circulatory overload is going to be when you are going to stop the transfusion. It's too much fluid. They can't do it. Place the client in an orthopnic position. So this is when they are sitting on the side of the bed, leaning over on the bedside table, kind of in that arched position to open up the lungs. We're going to prepare for diuretics, and so to try and pull off that excess fluid. They may need oxygen, and we definitely need to monitor their intake and output from now on to make sure that they are no longer retaining that fluid. Sepsis. Of course, stop normal saline, notify the provider, but we're also going to obtain blood cultures. This is usually a contaminant, so we need a blood culture from the client to identify what that contaminant is. Immediately start antibiotics or prepare to with the doctor's orders. These are usually going to initially be broad spectrum because we don't know what the contaminant is. And then once the blood cultures have returned, and then we know exactly what it is, then an antibiotic may be changed. The client may need vasopressors. These are going to be cardiac medications that will go into in the next two lectures. One of the next two lectures. So these are going to increase the client's blood pressure is the intent here. So with sepsis, we'll see that severe infections, their blood pressure drops dramatically. And so what the vasopressors do are increase that constriction on the blood vessels and increase the client's blood pressure so that they can perfuse again. If their blood pressure is too low, they're not perfusing their organs, and we need them to perfuse as much as possible so that the organs do not continue to shut down. Also, steroids are going to be probably administered to help boost the immune system and decrease the inflammation and inflammatory process that's going on. And then we need to send the bag that the transfusion was in, the blood bag, needs to be sent back to the lab, and they will obtain their own cultures directly from the bag itself. And then they'll, of course, compare it with the blood cultures from the IV that we obtained from our client, and to officially determine that that's where the organism came from. So to prevent the sepsis, we want to make sure that when we obtain our bag, our blood product from the lab, that there are rules for a reason. There is a timing rule for how long it's good after you get it from the blood bank. There's a timing rule for after you get it that you have to transfuse it completely. There's a rule of when you have to start it. There's a rule of how long it can be on ice. There's all these rules to maintain the integrity of that blood product. And if you do not follow those rules, then you are likely to allow an organism to start to grow. If it is warmed for too long, and then it's likely to have a microorganism start to grow in the blood product. So it needs to stay chilled, and it needs to be infused as fast as possible and tolerable by the client. Hyperkalemia reaction. This is, we're going to, of course, notify the provider, monitor for that hyperkalemia, and hypokalemia also may happen as a result. And then hypocalcemia symptoms. So at first we may have hyperkalemia, especially if there was some sort of hemolytic reaction that it was occurring. But then as that potassium is being filtered through the body, then you may end up with hypokalemia. So make sure you know the symptoms of both hyper and hypo, because both may be present or happen following each other. And then calcemia usually mimics with the potassium there. Now the last one, the growth versus host disease, transfusion associated. We're going to make sure that we notify the provider. This can usually at least 1 to 2 weeks later. And then we need to provide education to the client that in the future that any blood products that they receive have been irradiated. So our procedure for administering blood products. Before we can administer, we need baseline labs. What are the hemoglobin, their hematocrit? These are usually going to be what has determined the order. but by the physician, but you as the nurse need to confirm that I have this order. Why is it appropriate that this client is getting this order? So you see the hemoglobin is 5.2. Okay, yes, they probably need some blood products. Usually the rule of thumb is anything less than 7, you need to transfuse. So once we verify their labs, we get these baseline. So looking at their platelet level, the protein, albumin, the coags, their potassium levels, what their pH is, and their calcium levels. Again, remember all of those transfusion reactions. So the most information that we know baseline, the better that we can figure out what happened if they do have a reaction. So always be prepared. Then we're going to need to verify the prescription, the order, and the history of the blood transfusion, of any blood transfusions from the client. Has the client ever had a blood transfusion? Is this their first time? Or do they get them frequently based off of whatever disease process they're going through? Then we need to have a consent signed for receiving blood products. And then after all of that has occurred, we can take baseline vital signs. So this is going to be like immediately before you go pick up the bag. This isn't, oh, at 12 o'clock, the tech came around, did vital signs. I'm just going to write those vital signs down, and it's 2:30. No, you need a new set of vital signs very near to the start time of your infusion. So typically what we do is we go in, we get our full set of vital signs, including temperature, and then leaving the client's room, you go straight to the blood bank and you pick up your bag. There at the blood bank, you will have to verify the client's name, the client's MRN number, the blood type, consent, all of this. There's a checklist. And then once you verify that with the blood bank personnel, they will then hand off to you either in a brown paper baggie or in a cooler. Then you walk it back to your client, and essentially you're going to go straight there. You have already told your coworkers, you have already told your charge nurse, your HUC, or the secretary that I'm going to be busy and I'm going to be in this room, because you have to stay there. So don't start this process until you are clear and ready and you have nothing else to do but to sit in that room. You can bring your computer and chart, but you are to stay at the bedside after you have started this infusion for the first 15 to 30 minutes. Usually 30 is if they've had a history of a blood transfusion or if this is their first one. All other people, at least 15 minutes. And then you will be checking on them hourly. However, throughout this entire process, vital signs are going to be taken every 15 minutes. So you can either hook them up to an automatic machine. You yourself can go in there to do this every 15 minutes, or you can delegate to a PCT or CNA. So then we also need to make sure that during the procedure, we're going to assess the site for patency or any signs of infection. The client should have a 20 gauge or greater, and this is going to help prevent hemolysis. The smaller the gauge of the needle of the IV the transfusion is being infused through, the smaller those blood products are having to go in, and therefore think of the cells bouncing around. And if it bounces so many times to get into the blood vessel, it's likely to start breaking up. And it's kind of a cascade effect. So once one start to break, then the rest will follow. So we usually like to have 20 gauge or larger. They've actually seen that clients that have a 20 gauge or larger have a decreased risk for transfusion reactions, and especially the hemolytic transfusion reaction. So this is should be one of your pre-checks before you go into transfuse. So again, like I said, that we have your blood that you pick up from the blood bank, and you are going to have to start that infusion within 30 minutes. So by the time you get to the blood bank, depending on how big your hospital is, you have to walk it all the way back. And the same person that picks up the blood should be one of the 2 people that are going to be checking it off at the bedside. So again, make sure that you have everything ready and you're not going to be pulled away to go do anything else. You have nothing else to do for the next 30 minutes. So once you obtain the bag, you are going to plan to start the infusion within 30 minutes. After you've started the transfusion, you only have 4 hours from the refrigerator for whole blood, or 30 minutes for platelets, 1 hour for FFP and white blood cells, and then 30 minutes to an hour for albumin. After these time frames, your product is no longer good. You've now wasted that product, and you have to return it to the blood bank for them to waste it. And they will probably be pretty PO'd because of the shortage that we have, because you didn't follow directions. So make sure that you are fully and capably ready to infuse as soon as you pick this up from blood bank. When we hook up blood, it will be in a tubing that has 2 spikes at the top. So on one side will be a blood product and the other side will be normal saline. So this is going to help with infusing the normal saline after the blood product is finished, and then also to have it readily available for if a reaction does occur. You can use the same tubing for transfusing multiple products, but only 2 products. After the second one, you have to get a new tubing, and then you can only use it for that second unit if it's still within 4 hours. So remember, 4 hours is a good general rule of thumb for your whole blood and for your tubing. So tubing are only good for 4 hours as soon as you start it, and if it's within 4 hours, then you can have a second product. No more than 2. For documentation, we're going to need to document the client's blood type, the blood bank number from the blood that we picked up, the blood type that the bag was from as well, the total volume that was infused. So based on the product, it will be 50 milliliters, 250 milliliters, 200 milliliters, 175 milliliters. So this will be printed on the bag, so you'll have to look at this. Don't ever assume. You also document the time that the transfusion started, when it was completed, the vital signs for pre at your 15-minute mark, and then every 15 minutes after, any adverse effects that happened, and any actions that you had to take. Universal precautions are going to be utilized throughout the process, so make sure that you're doing proper hand hygiene and using gloves. If a transfusion reaction occurs, then of course, like I spoke about previously, stop the transfusion and notify the provider. And don't allow the remaining of the product that's in the tube to be infused. Disconnect it at that Y site and flush with normal saline. You're going to need to stay at the bedside and observe for any symptoms. And so this may mean that you're going to hit the nurse call light to let the HUC is my go-to, the secretary, different hospitals have different terms, to let them know that this is occurring. You might need someone to be sent to you for help. If they can make some phone calls for you, call the doctor, get them transferred to you so that you're not having to wait on hold, so that you can stay there and be there with your client. Because I'm sure not only if you're not, it's not just for you having to intervene and give medicines, but they're probably freaking out. So there's this therapeutic communication that you need to be very fluent in at this time. And so anything that you can delegate, delegate. Have the secretary call the doctor and transfer them to you when they're finally on the line. So that gives you another minute and a half, 2 minutes, hopefully not longer than that, for you to explain what's going on with the client, get them a little more comfortable, discontinue that tubing, and flush. We need to recheck the ID band from the blood bank, make sure that those numbers match. Sending the tag, the bag, and the blood and the tubing all the way back to the blood bank if a contamination is suspected, so like in that sepsis reaction. So a good rule of thumb is going to be just to save all of that regardless, and then call the blood bank and let them know also what has happened once all this has transpired and you have stabilized your client, you've gotten your orders from your physician. Last thing, so just make sure during this process, don't throw it away. Last thing, then call the blood bank and let them know, and they will let you know if they want it or not. We're going to need to obtain of urine usually. This is going to help with the hemolysis reaction. So that hemolysis, you're going to see those broken down blood products in the urine very shortly. So that's another part of education, to let the client know that they may see blood in their urine, and that's going to be expected, but still let us know. I would not let the client know this, but as a nurse, be aware that because of the broken down blood products being filtered through the kidneys, that if it gets dislodged, then we have a kidney injury. So blood being clotting and being stuck in the tubules of the kidneys. So be mindful of that and looking for any kidney injury, kidney pain, and watching their BUN and creatinine over the next few days. If it's a hemolytic, again, with what's going on with this process, we may need to just insert a urinary catheter so that it is free blood flow and we can see immediately and not have to incidentally waste or the client not tell you, things like that. So it might be necessary to go ahead and just insert a catheter while we're observing their urine and their kidney function. We're going to need to then repeat their type and cross match just to make sure that there wasn't an error, it wasn't input on the wrong client, and so the record shows that she's AB positive when really she's only A positive. Some sort of technologically error that may have occurred from the first type screen, or tubes that had gotten mismatched for someone that was drawing multiple tubes from different clients and got the labels mixed up. So we'll identify and rule out lots of different reasons of why this has occurred. So repeating that type and cross match and making sure that all of those checks are done so that the blood bank knows that this is in fact from this client. That way we can compare it to make sure that the client is really what blood type. At that same time, we're going to draw a CBC and probably a bilirubin to determine the amount of hemolysis. Because again, bilirubin is another product of what is going on with hemolysis, with those cells that are being broken down. So bilirubin levels are likely to be elevated in the immediate following reaction for hemolytic reactions. If a client is getting mass transfusions, we're going to need to repeat coagulation studies after every 5 units. So massive transfusion, they're getting usually because of trauma or some sort of bleeding disorder. A GI bleed is another reason. So they're having to receive multiple blood products back to back to back to back, usually very, very fast. There's a level 1 transfuser that a lot of trauma facilities have now, and I was one of the nurses to handle that and have the training on that. So you would hook up the blood product. It has 2 sides for the blood product to have on. So you would hook up one. You would spike it, prime it to the couple inches. You would hang it inside of the container, close the container, and the container has a pressure bag that then just slams it into the client. And while it is slamming that in the next 30 seconds, then you are hooking up the other one. So as soon as you're done hooking up and putting it in there, it's going back and forth. So you're just constantly hooking up blood product, blood product, blood product. But you need to be aware of there's a certain order that you do blood products in for massive transfusion. So that's a whole protocol, so that you are in the amount of time that you're hooking up. The other one is pressing that blood directly into their IV, and then by the time you hook up this one, you close it, it is doing that one, you're taking off the old one on the other side, and so it's just back and forth, back and forth. So massive transfusion. However, NCLEX wants you to do new coagulation studies every 5 units. We will redo coags in real life as well. But it's based on the protocol. It's not necessarily after every 5 units. So this is another thing that's a little bit different. But in NCLEX, and I'm sure evidence-based practice, the more often you do it, it makes sense that you're more closely monitoring and would be appropriate. So every 5 units is the key there for NCLEX. During this time, of course, we need to monitor the potassium level, calciums, and their EKG. For any cardiac dysrhythmias. As we are slamming more and more blood product into them, it is changing their electrolyte status, and especially at the potassium level. So monitoring for hyper and hypokalemia again here. Using a blood warmer is also going to be very key for massive transfusions, as these are just recently cooled to room temperature, and replacing someone's circulatory volume within minutes with cool fluid can cause shock. So to prevent hypothermia and shock in the client, there is a blood warmer that it's a little device that you hook up on the tubing, and it will warm it just prior to entering the client without warming the entire blood product. That has been shown to lead to like those sepsis reactions. So it'll warm the blood in the tubing just prior to going into the patient's body. And then, of course, when we're done, make sure that we document the blood type, blood bank number, total volume infused, time of the start, time of completion, vital signs, any adverse reactions, and any actions that were taken. And this is where it came from in your textbook, from your ATI Pharmacology textbook, chapters 25, 26, and 27. Thank you.